For ERCP in Focus, our speaker is going to be Dr. Mostafa Ibrahim. And just a brief intro. Dr. Mostafa is a Cairo-based gastroenterologist and hepatologist whose career bridges rigorous science and expansive impact. He was trained in Egypt and Belgium and holds a PhD from the University Libre de Bruxelles and has fellowship with ASGE and the Royal College of Physicians and Surgeons of Glasgow. He has channeled that expertise into founding ROEYA, which is a network of endoscopy centers and a training institute that carries advanced medical education from Cairo into Ethiopia, Uganda, and Kenya. Please let's welcome Dr. Mostafa Ibrahim as he begins the webinar proper. Thank you.
Okay, so I can start?
Yes, doctor, please go on.
Okay, first of all, thank you very much really for inviting me today. It's my honor and pleasure to be with you, and I will, as I said yesterday, I would love to come more and more to this even physically to cooperate, because I think we have a lot to do together. So I will move directly to the lecture. So again, it's a very big task to give a presentation in 30 minutes about all endoscopic management of biliary and pancreatic obstruction. I will do my best to cover a little bit the big image of everything, or the big a little bit of a zoom out for everything. So what is really the problem? Why we still have ERCP? So maybe if I'm giving this presentation in Germany, they will say, okay, Mostafa, ERCP is everywhere. However, I have visited most of the African countries. Still, ERCP is starting everywhere. So we have a lot of countries. I give you Uganda as an example. We have only one physician doing ERCP. So it's still, there is a big problem. A lot of cases I have seen in different countries in Africa where we have to do surgery for a very simple things that we can do in by ERCP. So ERCP is simply when you have an obstruction of the common bile duct, where you have after that the bile stasis, bacterial overgrowth, and then cholangitis, and then septic shock and failure. So a very simple stone can really cause failure and body failure and shock and death. So there is two big different categories. It's either benign causes of obstruction or malignant cause. So we start by the biliary causes, the benign one. The most common thing is very simple stone. Stone from the gallbladder, which moves to the common bile duct and then cause obstruction. And then it's strictures, chronic pancreatitis, post-operative stricture, sometimes also Merisi syndrome, which is a very small stone in the cystic duct compressing on the bile duct. Then the malignant, which is a lot, we see now a lot of this patient, pancreatic head cancer, cholangiocarcinomas, ampullary cancer, gallbladder cancer. Then for the benign part of the pancreatic causes of benign strictures, maybe 20 years ago, we don't see this a lot. It's only in Europe and the States. However, I see now a lot in Egypt and in different African countries, also a lot of pancreatic stones, pancreatic strictures, and even also pancreatic divisum. And then malignant obstruction, which is caused by also tumor, like neuroendocrine tumor or IPMN, which obstruct the main pancreatic duct. So it's very important in ERCP. I will give you a very short story. Maybe 20 years ago, when I started my fellowship in Belgium, my mentor there told me, Mostafa, why you are here on my first day of this training? And I told him, I'm here to learn ERCP. He said, no, you can go back home. You are here to learn about hepatobiliary disease. So it's very important for all our trainees and all our colleagues attending this session to understand patient selection and when to do and what to do and what not to do is very important. So ERCP, yes, this is the guidelines. We know that ERCP is the first line diagnostic test to treat biliary obstruction. However, we need to do a lot of things before. Diagnostic ERCP is not anymore available worldwide. It's only therapeutic ERCP. So we need to do labs, we need to do all the liver function, all the bilirubin, all the tumor markers. We need to do a minimum of one imaging technique. The best thing for sure is MRCP. However, we should do CT, for example, EOS, all other things to confirm what we are going to do. We should not do any more diagnostic ERCP. So as I said, the clinical testing, CT or MRCP, maybe EOS, and then we know what we are going to do in ERCP. So what we should be ready. So this is something very important. I have been the privilege to do a lot of educational events through Africa. The main problem in different countries and different cities of Africa is there is no proper platform. And this is why I'm extremely happy today to do this with the collaboration of Fujifilm and Uni-medical, simply because I can teach all of you for the next 1 year a lot of ERCP, but without having the correct platform in your room, in your endoscopy room, you will never be able to do ERCP. So we start by a duodenoscope, a side viewing the duodenoscope with a working channel and elevator. So this is our newest duodenoscope. I will leave, again, my colleagues in Uni-medical to explain this more in details. However, a lot of good things. Number one, okay, forget about Fujifilm. Let's speak about in general. What is the best duodenoscope? Number one, a duodenoscope with a distal tip that you can change, you can remove. Why? To clean the scope and disinfect the scope to avoid any bacterial overgrowth. Two, a wide channel duodenoscope. So this is number two. Number three, a good image, so which give you a very good high definition image. Number four, it's a very good lock with the elevator. When you close the elevator, you are 100% in a good locking the guide wire. And this is exactly what we have in the duodenoscope. So a big working channel, something called G-lock, where you lock your guide wire or your stent or anything. And then, as I said, a single-use distal end tap, and a very good, you can see the image, a very good image with all the high-resolution image, BLI, LCI. So when you start, okay, I would like to do, Mostafa, tomorrow an ERCP, what you should do? Number one, there is a lot of things should be done before, like fasting, like having a discussion with the patient, discussion with the anesthesiologist, giving the patient antibiotic, which is very important to avoid cholangitis, understanding also your setup of the radiation safety, everything. And then something you should never forget, giving the patient rectal NSAIDs. So giving the patient rectal NSAIDs, this is for the guidelines. This is the best tool to avoid ERCP pancreatitis. So as I said, this is something mandatory now. It's not an option. It's a prophylactic thing to give it to all our patients. Then, when we start ERCP, we need to understand the first thing, we have a very small papilla that we need to go inside. So this is the idea. We need, first of all, I will give you another advice from my mentor years ago. Papilla, I will just repeat the sentence. Mostafa, papilla is a very fragile organ. So we should not really fight with the papilla. We need to stand in front of the papilla, inflate our duodenum, see, plan what we are going to do. What is the tools, how we are going to really cannulate this papilla. So how to start? Start by cannulation only, or the success, how to assess this. There's a lot of study showing that the endoscopist himself, regarding his learning capabilities and his tools, he is the best one to decide. Because this question about injecting first, guide wire first, it's a long discussion in the literature. However, you should start doing what you have learned. For example, I do the combined technique, which I put the tip of my sphincterotome in the papilla, ask my nurse to push the guide wire very slowly, only once. If it moves very easily in the bile duct, it's okay. If not, I will inject only 0.5 milliliter just to see, to understand the anatomy of the start of this very start of the bile duct inside the papilla. So in general, we have two different types of ERCP, what's called short wire or long wire. It's very simple. It doesn't really matter. So it's all about your setup. If you're really dependent on the nurse like me, I use all the long wire, which means the exchange, everything will be from this part. from the distal part of the instrument. If you do more of ERCP by yourself, you are going to use what's called short system. Again, we have the papilla. We decided to cannulate. As I said, I start by pushing the guide wire. If the guide wire go to the pancreatic duct, I will wait, come back one more time. If it's a second time in the pancreatic duct, I'll stop, leave a pancreatic duct guide wire, and put a second guide wire in the biliary duct, which is called double guide wire technique. Other thing that we can do, we do a very small sphincterotomy in the pancreatic duct if we go there by mistake, and then after that we do the biliary sphincterotomy. Again, another thing, put a very short stent in the pancreatic duct to straighten the papilla, and then cannulate beside this stent by a sphincterotomy. When you fail all of this, you may think about the needle knife. So my advice here, please don't start using the needle knife very early. As you know, in Fujifilm now we have the complete portfolio. We have the scopes, the duodenal scope, but also we have all the type of biliary, hepatobiliary accessories, from the cannulotome, from the cannula, from the guide wires, different things. We have straight guide wires, J guide wires. Okay, then how to start? Okay, I put my guide wire, I cannulated the bile duct. What should I do? Two different things. Number one, sphincterotomy, easy, with an electrosurgical unit. You start cutting the papilla. This is one. Second thing is to dilate the balloon. Normally we can dilate the sphincter by the maximum diameter of the bile duct itself, which means that if you have a bile duct dilated of 10 millimeter, you can dilate only to 10 millimeter. And then you can combine both of them when you need a very large sphincterotomy and sphincteroplasty. Usually it depends again. This is why, as I said in my previous point, it's very important to understand. If I'm doing ERCP for a very small stone, I will do only sphincterotomy. If I'm doing an ERCP for a very big stone, I will combine sphincterotomy and balloon dilatation. Then, number one is to extract the stone. So we have two things to extract, very simple, either a balloon or a basket. So you also know this is our new instruments. So the Tortega, the balloon, which is a very, very, very good balloon. Two different subtypes, one of a distal injection one or a proximal injection one, depending on where you would like to inject. And then the Rockstar, which is, I think, is one of the best extraction balloon in the field for a lot of reasons. Number one, when it catches the balloon, the stone, it twists around the stone. This is one. And then if for any reason you are stuck by the stone, it changes automatically to a mechanical lithotripsy tool. So again, when you are able to remove the stone, this is good. If not, it's very important to leave a guide wire in place. And then after leaving a guide wire in place, we have a lot to do. Number one is just simply put a stent. What is the meaning? What is the reason of the stent? Number one is to do decompression of the bile duct, to decrease the size of the stent, because it will have less water and less fluid. It will be more solid. And then number four is to avoid cholangitis also. So this is number one, you put a stent. If not, if you are in a rich country, a rich hospital, and you have EHL, it's another story, which is called cholangioscopy guided EHL. So this is also our cholangioscope, which is a very small scope. You put it inside the working channel of the scope, where you're able to visualize. And the good thing of this cholangioscopy, you don't need any extra processor. It's a very simple iPad. You just connect the cholangioscope to it. And then you go inside. It depends what you need to do. If you would like to take biopsy, it's okay. Or here, for example, this is an example, a video example of doing EHL. So this is the cholangioscope. This is our EHL probe. We start breaking this stone into particles. When it breaks into particles, it will be very easy to remove. Then the second etiology of ERCP is strictures. So depending, we need to decide, is it really, is it a benign one, which only needs dilation or stent, or it's a malignant obstruction? So for malignant obstruction, you need to know before you start what you are going to do. Is it a resectable tumor? So I will put a plastic stent just as a bridge to surgery, or it's an unresectable tumor, I'm going to put a metallic stent. And then the question will be, which metallic stent? It's very important. It's very simple. If you have a cancer head of the pancreas, you can put either uncovered stent or a partially covered stent. If it's a hilar stricture cholangiocarcinoma, you should always put an uncovered stent. You should never put a partially covered stent in cholangiocarcinomas. So this is the hilar strictures. Another very important advice when you deal with hilar stricture is the interventional radiologist. Sometimes it's almost impossible to drain all the segments. So when I do ERCP for example, for business 3 or 4, I will always have interventional radiologist ready for me. I can drain, for example, the right system, and then he will help to drain externally the left system. Antibiotic is mandatory, and very important that you need to drain whatever you have put contrast in. If I inject contrast in the left system, I need to drain the left system. If not, for example, if the right system, I need to put stent. As I said, always uncovered stent. Cholangioscopy is nice in this patient, sometimes only to take biopsies, but also sometimes to guide your guide wire. So if the patient cannot afford, or the hospital cannot afford putting a metallic stent in the benign stricture, which is this one, we have two different. So for benign stricture like chronic pancreatitis or post-operative, we have either two things: to put multiple plastic stents or to put a one fully covered stent for 1 year. So as I said, this is all the stents that we have in the mid-work. Again, we are not only putting just stent. It's very important to understand and to take biopsy and to take some biopsies from these strictures. Then the second very common cause of malignant biliary stricture is cancer pancreas, and this is where we always put, as I said, it depends. Resectable tumor, I will put a plastic stent. Unresectable tumor, I put either an uncovered stent or a partially covered stent. If all of this failed, if I cannot really drain anything, so we still have options, which is EOS. So EOS biliary drainage, now it's very clear in the guidelines, should be the first line treatment when we fail in ERCP. So we have two different techniques. Number one, either to do for distal stricture, for cancer pancreas, what's called choledochoduodenostomy. It's very simple, putting a stent just here at the bile duct. This is the cancer pancreas. We cannot go with ERCP here. We go in the first part of the duodenum by EOS and put a stent here, normally a LAMS. So this is the guidelines confirming LAMS should be done as the first line of treatment in case of failure of ERCP. The other thing in cholangiocarcinoma, when we fail from here, we fail to pass the tumor from here, we can go by EOS and drain the left system by a stent from the stomach to the left system. And then the right system is another story. Either we do it externally by radiology, or there is a little bit of few trials saying that we can do something called bridge. We can bridge a stent from here to bridge the left and right system. So a lot of literature, a lot of guidelines confirming that this should be the primary treatment in case of failure of ERCP. With all the trial, this is a very good randomized control trial showing a very good clinical success. At the end, we need to understand, we are not doing simple gastroscopy, we are doing a big thing, ERCP, so there is complication. We need to understand about how to manage pancreatitis, pre-operative and post-operative. Perforation will happen. My advice in perforation, if you perforate a very small perforation while you're doing sphincterotomy, it's very important, always keep a guide wire in place, put a plastic stent. This will save the patient from biliary leakage. And if bleeding happens while sphincterotomy, always control the bleeding while you are doing this. So in a nutshell, I will share with all of you this presentation, the slides. So this is how you should go. So in few minutes, in stone, do a sphincterotomy, try to remove the balloon. If you fail, do mechanical lithotripsy or EHL via cholangioscopy. Malignant stricture, if it's an unresectable tumor, put a SEMS and then go with the cholangioscopy, take some biopsy. And if you fail to do this, do EOS drainage. In malignant obstructions, hilar stricture, do MRCP first, understand what you are doing, put stents right and left, always uncovered. In benign stricture, you need to exclude malignancy and either to put multiple plastic stents or a fully covered stent. So again, there is a lot of things happening in the literature now that regarding the disposable cholangioscopy. A lot of centers now trying to do EOS first, even by you will have a little bit of presentation after me about our new EOS scope that we also can do combined EOS and ERCP in one scope. So my take-home message, ERCP is the only therapeutic tool now that we need for biliary system. You need to train very well before you start. You need to set up your room before you start. Guide wire cannulation is the best. When you fail, we can go with contrast. Giving the patient rectal NSAIDs is mandatory before the ERCP to prevent pancreatitis. For benign lesions, you can put plastic stent. For malignant irresectable tumor, you always put covered stent, either hilar uncovered or pancreatic partially covered. Cholangioscopy will do a lot. And then put in your mind, when you fail, you should be ready by EOS. Thank you very much.
Thank you very much, Dr. Mostafa, for that very enlightening webinar. I don't know if we have any questions, but for me, I'd like to ask Dr. Ibrahim, patients living with chronic liver disease or hepatitis, right? What are some of the hepatobiliary complications that may eventually require ERCP intervention?
You mean for patients with hepatitis?
Yes.
Okay, so this is a very good question. So hepatitis as a medical disease, normally you don't have obstruction. So in hepatitis patient, when they have the bilirubin increase, it's more about medical cholestasis, which is indirect bilirubin which increase. However, in patient which there is a lot of patient in hepatitis B and Africa HBV, we see in this patient, if even the patient is very well controlled on antiviral treatment, we see in these patients HCC, which is tumor, hepatocellular carcinoma, which can arise very early, even before cirrhosis. And in this patient, you have always this HCC compressing on the bile duct where you have obstruction. So it's very important in this hepatitis B patient to follow this patient regularly with ultrasound and alpha-fetoprotein every 3 to 6 months to make sure if there is a very small HCC to treat it very early before obstructing the bile duct.
Oh, thank you very much. I don't know if there's any other questions for Dr. Mostafa. In the chat room, Dr. Evaristus said he was trying to unmute. So, Jude, can you unmute Dr. Evaristus so that he can ask his question, please?
Thank you so much. I wanted to hear your techniques on the EUS guided ERCP when we have this ampullary tumor.
This is a very good question. So in ampullary tumors, you have to think first about two things. Number one, if this ampullary tumor is invading the duodenal wall and you can see really a big ampulloma, you have two options. Option number one, you need to make sure is it resectable or not. If it's resectable endoscopically, I will proceed by an ampulectomy, which is very simple, like polypectomy. You put a snare and you just simply do the polypectomy if you are sure that this is an adenoma, not invading deep invasion. If it's invading deep invasion and it's irresectable tumor and no surgery will be done, I will treat it as a cancer pancreas, which means I will I will cannulate and do a very wide sphincterotomy, and I put a partially covered metallic stent. So again, depending, it's the big challenge, technically challenging this is to cannulate this tumor. Sometimes it's when you cannot see really the opening of the papilla. So in this condition, what I do, and this is why it's very important to have also EOS in your hospital, what I do, I go with the EOS scope, I puncture the first part of the duodenum, I do a rendezvous for myself, which I push a guide wire from the first part, and I see the guide wire coming out from the ampuloma, and then I catch it, I put a stent. It's a little bit challenging technique, but I use it as the last option when I fail cannulation. However, again, it's very important before you do anything to make sure if it's resectable or not. Because if it's a resectable, you treat the patient totally when you do ampulectomy.
Thank you. Thank you so much.
Okay, I have only one comment. So as I said in my lecture, I will share my presentation with a Uni-medical team. They can share it with all of you. And please, even afterwards, if you need any question, I will be more than happy to answer. I think there is one question. I understand currently that you are practicing in Egypt. We have a training center. Yes, we have. So yes, we have Broya Training Center, which is the biggest training center all through Africa. We will be more than happy to support you. We do a lot. In countries in Egypt, and also we travel a lot to teach people. You can communicate with Uni-medical team. I'm part of the team, so I can do a lot in this in teaching ERCP with all my pleasure.
So I'll just share my slides very, very briefly. It's just to talk about the equipment we have from Uni-medical.
Yes, please.
Okay, thank you very much for having joined this webinar so far. So I'm just going to be very brief with my own presentation. It's just an overview of the equipment that is necessary for ERCP. Of course, you can't do your ERCP if you don't have an endoscopy setup, and most importantly, a duodenoscope. And with Fujifilm, good enough, we have the full range of endoscopy system, the Elixir portfolio, ranging from the 600 EP6000 to the VP7000 and the newly launched 8000 series system. Good thing about all this is their advanced features, multi-light technology, real-time AI tissue enhancement modes, and everything you need for visualization and for characterization. So like I said, different processors, endoscopy processors for ERCP, for GI endoscopy in general. Now, our endoscopy, our duodenoscope, the ED840XT, it's a next generation therapeutic duodenoscope, and it is engineered specifically to improve ERCP outcomes. So when things like difficult biliary cannulation, stone extraction, pancreatic duct intervention, stent placement, very important, and even the complex therapeutic ERCP, with the ED840XT, you know you're ready for that. One good thing about the duodenoscope we have is that it has a 4.5 mm working channel. So what this means is that it takes a lot of therapeutic devices, from stones to baskets to balloons and every consumable that you need, without having fear of causing some form of leakage in the internal structure of the scopes. The elevator, though we can't really see the elevator, but the elevator has been redesigned with greater range of motions for improved accessory manipulation. Then there's the new G-lock. You can lock your guide wire in place, and you're sure of where you're going to. Advanced force transmission. So what this means is that there's efficient scope control, and then of course patient safety is also at the end of it. Of course, it's slim and it's easy to maneuver. For visualization, a lot of advancements in terms of HD imaging. We have the BLI, which is the blue light imaging. And then there's, of course, LCI and also ACI. If you look at the images there, these are live pictures taken from procedures. You can see the mucosa, something like outgrowth from the mucosa, looking like a polyp. So with BLI or even LCI and ACI, you're able to detect very well. It gives better visualization of papilla, improved anatomical orientation, and of course, increased confidence during therapeutic interventions. One other thing is that the duodenoscope is now designed for safer reprocessing. So they all have single-use detachable distal end cap. So it's detachable, sterilized, and what this means is that enhanced patient safety. There's reduced cross-contamination risk and faster turnaround between procedures. So that is what this future is for Fujifilm duodenoscope. Now, just key takeaways from here. Remember, it has a 4.5 mm therapeutic channel, so a lot of consumables can go in there one at a time, be it your basket, be it stent placement, guide wires and all. And of course, the advanced G-lock. So with the G-lock, you can lock your guide wire and make it really stable while you exchange consumables. And improve elevator for precise accessory manipulation, outstanding maneuverability with advanced force transmission, high definition image with your BLI, LCI, and even ACI. You're able to detect high vascularity in the mucosa. Of course, the single-use distal cap that makes for enhanced infection prevention. At the end of it all, the duodenoscope from Fujifilm has been designed to improve efficiency, precision, and confidence in complex ERCP procedures. Now, this is where it concerns us because, of course, we know that at the end of the day, besides patient safety and all, Naira and Kubo really matters. So what we've done is to do a bundled offering for our endoscopy system. There's a bundled offering for the GI part. There's a bundled offering for ERCP bundle. And for those that already have the Fujifilm systems, of course, we can do, there's a promo offer for the duodenoscope, single standalone duodenoscopes. This is to make ease of access to the equipment. Because 10% discount, 60 days validity, and then my phone number is there. Thank you very much. Oh, there's a question.
Yes, please elaborate on the use of covered and uncovered in cholangiocarcinoma. So the answer is very, very simple to Dr. My friend, Christopher. No, so the answer is very simple. Cholangiocarcinoma, no covered stent. So you should not put any covered stent in any cholangiocarcinoma affecting the hilar or hilum stricture. The only partially covered stent that you can use in cholangiocarcinoma if the cholangiocarcinoma is very distal, like in the very first part of the bile duct, which is like cancer pancreas. This is the only way, the only indication you could put a partially covered stent. However, any lesion affecting the hilum, you should not put any covered stent. And the answer is why? The answer is, this is the right and left stent. If I put a covered stent here, the covered stent will block the drainage of the other system. So this is, you have cholangitis and abscess in few seconds. However, an uncovered stent, so like this, if even I put only one stent in the left system, the other system will drain through the mesh, the uncovered mesh of the first one. So this is why in cholangiocarcinoma, you should not put any covered stent by any means.
Okay, so at this junction, I don't know if Samuel is here. Samuel is the head of sales. He will just be giving the closing remarks. Mr. Samuel.
Thank you, Manuel Pasi. You've done a good job. Thank you, everyone, for joining this meeting. Thank you, Professor Mostafa Ibrahim, for a well-thought webinar that you have delivered. I know we have learned a lot. We have learned a lot. And more of this will be coming subsequently. We need to have at least to have twice within a quarter. And we also carry our doctors, our professors along on the topic which will benefit them, not any kind of topic. We have to find a topic that will benefit our own medical doctors and professors here, not just bringing any kind of topic to just come and deliver or just talk about. So I really appreciate you for joining, and I'd appreciate Professor Mostafa once more again for delivering this webinar and making able to understand. I feel, you see, the question was not much, because if someone delivered his webinar presentation well, there's a limit to question that you see, because everybody understands something out of it. We have gained a lot from it. I also appreciate you. And
thank you.
Let me put this in clear. This is Uni-medical in collaboration with Fujifilm, our partner. And I'm telling you for free that Fujifilm endoscopy is one to reckon with. I don't know how many people that have it here, but I'm telling you for free. Please try as much as possible to get one. Compare it with others that you had before. You see that what I'm saying is just a fact. So thank you, Professor Mostafa. Thank you, everyone that have joined this webinar. Thank you, and also our doctors and our professors who also send invitation as time goes on also for another webinar. Thank you for being here, and have a great day. May God bless all of us, bless our country, and bless our company also. Thank you, everyone.
Thank you, everyone, for attending this webinar. We'll also keep in touch for future webinars as well, and we hope that you would also be available to attend. So we'll just call it a day. I'm sure we all had one thing or the other that we were doing, but we took our time to attend this webinar. Thank you very much once again, and have a wonderful rest of the day. Thank you.